So to start with, as we observed that COVID was rampant all over the world with the pandemic, but initially we thought that it is not infecting the children, and usually it is a milder disease in children. However, amidst April 2020, there was eruption of cases with severe manifestations, and and around the same time, NHS issued a warning against a growing number of such cases with multi-system involvement. And WHO then recommended the term as multi-system inflammatory syndrome in children and adolescents temporarily related to COVID-19. And similarly, CDC and other institutes also issued a warning against such cases. So, what is the relation between MISCZia to COVID-19? As we can observe from this graph, is that the blue line shows the COVID cases, overall COVID cases, and the other brown line shows the number of MISC cases. So, we can observe that there appears a time lag between the appearance of COVID cases and the MISCZia cases. And this time lag is usually between 3 to 6 weeks. Similarly, from European and American countries, it was observed that after there was a surge of COVID cases, and after following the COVID cases with a gap of around 3 to 6 weeks, there was an emergence of MISC cases. And as the COVID pandemic started to decline, the MISC cases also appeared to decline. So, what is the possible mechanism for between how COVID causes MSC? Is that multiple hypotheses have been postulated. One is that there is a post-infectious process hypothesis, which states that there is formation of antibodies against SARS-CoV, and and then these IgG mediated there is a enhancement and hyperimmune response, which causes cytokine storm. And other postulated mechanism is there is a delayed cytokine storm. So after heavy initial viral load, there is initial blockage of type 1 and type 3 INF response, but later there is a delayed hyper response which causes cytokine storm. So all these mechanisms, basically there in the end there is a cytokine storm which causes this multi-inflammatory syndrome temporarily related to COVID-19. So basically, in mostly when the COVID infects children, it is usually a milder infection in children with a normal immune response. However, when the abnormal immune response occurs, there is production of these non-neutralizing antibodies and T cells, which can cause febrile children with elevated inflammatory markers, or in adult it can manifest as delayed inflammation in adults with severe disease, and it can either manifest as Kawasaki disease like MSC or MISC. So, coming to the clinical features, the persistent feature is a universal feature. Persistent fever, which is seen in almost all patients, and it is lasts more than 3 days, which leads to suspicion of MISC. Other than that, most common is the gastrointestinal symptoms, and subsequently, other than that, myocardial dysfunction, shock, skin rashes, and bilateral non-purulent conjunctivitis, mucous membrane involvement. These features are overlapping with Kawasaki disease. Coronary artery abnormalities in the form of coronary artery aneurysms are also seen, and respiratory involvement is less commonly seen as compared to adults. Other than that, serositis and multi-organ failure can also be observed in MISC. So, with the emergence of few cases, then we got to see multiple cases from different areas. So, most often we can see that abdominal pain and LV dysfunction and patient presenting with shock other than with skin manifestation was reported in all the series, and most of these patients were being treated with steroids and IVIG, and mortality was around 5% in all these studies. So we have subsequently data from our country also. So the subset of our patients correlates with those of the Western studies with GI symptoms and cardiac symptoms being the predominant. Coronary artery abnormalities are also seen similarly. However, the mortality that was seen in our subset was around 10% that was reported in different studies from India. So from Indian data here also we can see that it is comparable to the West, that the GI symptoms and the cardiac symptoms are predominant, and the mortality, as I told, it is high, around 10%. So attempts have been made to classify this MISC, and it can present in 3 subsets. One is the febrile phase and inflammation mostly, which is seen, and in these subsets this is usually a milder subset. In also we can see there is evidence of COVID-19 infection, but CRP elevation and troponin elevation is not very high. The other is the shock myocarditis subset, in which we see mostly the patient will have shock at presentation, and their CRP and troponin are elevated highly. The other is the Kawasaki disease-like presentation. In these, like other, we can see there are abdominal pain, rash and coronary artery aneurysms are more prominent, and there is also evidence of SARS-CoV infection in this. So how do we differentiate between Kawasaki disease, toxic shock syndrome, and MISC? MISC usually is seen in ages of around 8 to 10, while Kawasaki is seen in less than 5 years, and toxic shock syndrome is in more than 10 years mostly. And the Kawasaki disease, usually cutaneous sign will be more prominent and lymphadenopathy will be more there. And hemodynamic instability usually is seen more in MISC and it is rare in Kawasaki, whereas cardiovascular dysfunction is more common in MISC, while coronary artery aneurysm, though seen both in MISC and Kawasaki, are more commonly and more bigger aneurysms are seen in Kawasaki disease. And lab-wise, if you want to differentiate inflammatory markers, and thrombocytopenia will be observed more in MISC, while in Kawasaki disease and toxic shock syndrome, there will be neutrophilic leukocytosis. So coming to the diagnostic criteria, we have different diagnostic criteria, but the one I will be discussing is the one proposed by the WHO. So for diagnosis of COVID and with MISC, we need to have at least these: fever for more than 3 days, and history of preceding COVID infection, which is supported by lab evidence with multi-system abnormalities and lab investigations showing increased inflammatory markers. So, for WHO criteria of MISC says that a child should be up to 19 years of age with fever more than 3 days. There should be evidence of COVID-19 or there should be a history of contact with COVID-19. There should be elevated markers of inflammation, and there should be no other obvious bacterial infection. Along with that, there should be 2 of these features, which include skin finding, which are in the form of rash or bilateral non-purulent conjunctivitis or inflammation, or hemodynamic instability as hypotension or shock, cardiac dysfunction as seen on echo, and coagulopathy or gastrointestinal dysfunction. So there is a stepwise algorithm suggested by many authorities, including our Ministry of Health and Family Welfare, which states that if the patient has these features, if he has none of these features like fever more than 3 days linked with SARS-CoV and clinical features suggestive of MISC, then we should search for alternate diagnosis and monitor for evolving feature of MISC. And we should proceed with further investigations, which include cardiac investigation like echo, troponin, inflammatory markers, procalcitonin, fever. However, if the patient has these features, all of these 3 are there, then we should suspect MISC. And if patient has shock-like features and patient is sick to start with, and if the patient is not sick, then we start with the basic investigation, which includes CBC, metabolic profile, SARS-CoV serology or RT-PCR, and blood culture. And if the screen is positive, like if CRP is more than 5 or ESR is more than 40, and one of these is there, which include ALC less than 1000, thrombocytopenia, hyponatremia, neutrophilia, or hypoalbuminemia, then we should proceed for the tier 2 evaluation, which was discussed previously. And if the patient has shock-like features to start with, then simultaneously we should order all these battery of investigations, and other than that, working up for common tropical infection. And if the criteria fulfills for MISC, and patient has cardiac dysfunction, shock, coronary involvement, multi-organ dysfunction, life-threatening condition, then we should start treatment for MISC with IVIG and steroids. Other than that, we should rule out the tropical infections. And if none of these is featured, then we should rule out infection before starting the treatment for MISC. So, coming to the treatment, that main treatment for MISC is like supportive. One is in the form of supportive treatment, which includes antiemetics, antipyretics, and fluids, and the mainstay of treatment is IVIG and steroids. So, depending on the type of presentation of MISC, if MISC presents with shock or multi-organ dysfunction, then we should proceed with IVIG along with methylprednisolone and empirical antibiotics. However, if the symptoms persist and they don't seem to resolve, then we should proceed to methylprednisolone pulse and consult specialists for starting biologicals, which include anakinra. And if the patient has Kawasaki phenotype also, then we will start with IVIG and methylprednisolone, and then we can also consider for biologicals in these patients also. And if the patient is without shock, then without IVIG, we can go ahead with methylprednisolone. So there are significant challenges in management of MISC, especially in our subset, where we can see there is a significant overlap with tropical infection, and decision to administer IVIG should be individualized, and cardiac dysfunction and coronary abnormalities should be documented, which is not easy in our subset of patients, because these facilities are not available, and these patients should be ideally managed in PICU ICU, which also is a limitation. And other than that, the treatment which involves IVIG and interleukin 6 inhibitors are also costly. So I will conclude that MISA, though it is a new spectrum of vasculitis and inflammation linked to COVID-19 infection, and it has a wide spectrum, and spectrum is similar as observed in Western countries. There is a significant overlap with Kawasaki disease, tropical infection, toxic shock syndrome, and the treatment involves steroids, IVIG, and second-line agents includes tocilizumab, interleukin-1 inhibitors, and antivirals can also be considered in selected cases. And the suggested algorithm may help us to diagnose these patients and exclude other infections. Thank you.